So as Molly said, this one is a new one. We're going to go through this. I've got some stuff that I'm going to add in that's not in the corporate PowerPoint. And you all have a handout. It's two-sided. And we'll talk a little bit about it. But essentially it summarizes some of the stages of COPD on the one side, and then just some of the symptoms and stuff that the clients have. And so I want you to remember that COPD, so at the end of the class, we're going to be able to describe the symptoms, we're going to talk about the complications, and we're going to also talk about always what you do as caregivers to help support your clients. But COPD in and of itself is a group of lung diseases that can obstruct the flow of oxygen. Okay, and so 10% of the individuals in the that are 40 and older have COPD in this country, in the United States, and it is the 4th rated cause of death in the United States at this point in time. So over 120,000 people die a year of COPD, and what happens is that we have, as we breathe in oxygen. It goes down our windpipe, our trachea. We have bronchioles that it goes down, and then they branch off into bronchi, and then areolas at the very bottom. And so we have our nose, the trachea, we have our lungs, and we have our diaphragm, which are all part of our breathing process. And what happens with COPD is that those branches get obstructed, okay? And patients end up bringing oxygen into the lung, and it doesn't escape. Okay, and we're going to talk about that in a minute too. Smoking is the biggest cause of COPD in this country, and if we think about it, 20% of COPD is caused by exposure, like chemicals and toxins and things in the air. So that means the other 80% is considered smoking related. Okay. And when I was talking earlier too, when we're thinking about a age group, and so quite a few of you are within my age group, when I nursed 45 years ago, we smoked in the hospital. We smoked in the break rooms. The patients smoked in their rooms. We smoked on airplanes. We smoked in restaurants. So even if you weren't a smoker, you were exposed to secondhand smoke, right? And so all of us have had some exposure to smoking. And so it affects us in ways that sometimes we don't even realize. So let's see what we got here. So before we go into, I'll just mention this first. So emphysema and chronic bronchitis are two of the most common conditions associated with COPD. You don't have to have them to have COPD, but often they become like the comorbidities and the problems that people develop. With the chronic bronchitis, what happens is there's an inflammation of the bronchioles, and so that's essentially an infection. And in order for you to be diagnosed as chronic bronchitis and not just having an episode of bronchitis, so I had an episode last December, I'd never had it in my life, and I was treated. You have to have a productive cough for at least 3 months, and it has to happen 2 years in a row. Okay, so that would be what they would consider the beginning of a diagnosis of chronic bronchitis. Pardon me. Emphysema, on the other hand, emphysema helps to destroy the elasticity of the areoles in our lungs, and so, as I was saying earlier, the air goes in our trachea, down the bronchioles, down the bronchioli to the areoles, and that's where the gas exchange is. So that component of your lung is at the very bottom of your lung. And as you breathe in, that component has a vascular system so that blood comes through the areoles. It takes away the CO2 that's in our system, and it gives that back to the lungs, so we exhale the toxin, and then it takes the oxygen from the lungs to our tissues. Okay, so that's sort of how how it works organically. And if there's a problem there, and if there's a problem with that gas exchange, then we're not getting the oxygen that we need, and we're not getting rid of the carbon dioxide that we breathe out, okay? And so let's just take a couple of moments to take a really deep breath, okay? Let's just do some deep breathing. Now, as you inhale, you think you're finished inhaling. I want you to keep inhaling, because you can inhale a lot more than you think you can. And when I taught yoga, we talked about deep breathing, right? So inhale, keep going, keep going. Exhale, keep going, keep going, keep going. You feel your core engage when you exhale, right? And that core is assisting that diaphragm. So we really have a range of breath that we don't utilize. We can take a deep breath in, we can take a really deep exhale, but we actually breathe in between. Our natural breath is somewhere in between the range that we're able to breathe, okay? And so just an example, an exercise to give you a sense of what it's like to have COPD. Take some deep breaths in and out. And you don't have to exaggerate them. And now on your next exhale, after you inhale, on your next exhale, exhale halfway. Now hold that air and keep breathing. You feel it? You feel how it becomes challenging to breathe because you've got that expansion already, that air there. So with COPD, air gets trapped in the lungs. And so it's really hard to really continue to take that deep breath and exhale because you'll never get all of that air out. And that's the sensation that people have when they have, as best as we can simulate it when you have COPD. Okay? So the diaphragm is an important component of our breathing system. And some of you know my husband's a pulmonologist, so I stole a slide from him. Okay. And so the slide closest to me is the normal, it's a normal chest, right? And it's got a normal sort of diaphragm. You can sort of see a demarcation. Our diaphragm is like a dome, okay? And it's normally like a dome. And what happens with COPD is that the diaphragm flattens. So when we inhale, the diaphragm naturally flattens to bring in the breath and presses the muscles of the chest wall out. And when we exhale, the diaphragm normally takes that shape back as a dome to help the lungs deflate and brings the chest wall in. Well, with COPD, the diaphragm is already flattened, so that it can't find that natural elasticity to help with the exhale. So what happens is that it can't bring those chest wall muscles in the way it should, okay? And this is an example of a barrel chest. So as people with COPD develop and progress, their chest becomes enlarged up top. There's normally, you can see how it's wider up top because of the air that's stuck in there in the lungs that can't be expressed, okay? So that's just an example on X-ray of what the difference between a normal chest and the COPD may look like. So the three cardinal symptoms, the three symptoms that you're going to go to your doctor with and say, this is happening to me all the time, this is why I'm really, really uncomfortable, are going to be shortness of breath, persistent cough, and chronic cough that produces either clear, white, yellow, or greenish mucus. So someone was asking earlier, mucus, sputum, it's a different word, but it's all the same thing. Those are the three cardinal symptoms. And if it's at the point where that mucus is green, that probably indicates that there's an infection going on, okay? Because generally, our mucus is clear when we cough it up. If we get sick and we're coughing and we're bringing something up, it's usually clear, maybe light yellow. When it turns to green, that means that there's an infection going on. But the other symptoms of COPD might be wheezing, the chest tightness, a lack of energy, and the fingertips and the fingernails become cyanotic. They become blue, and the lips can become blue because you're not getting the oxygen that you need, okay? So these would be common symptoms, and as I said, the first three are the cardinal symptoms. When you go into your doctor, these three are going to be there, and that's what they're going to be looking for. In order to diagnose COPD, you're going to do pulmonary function tests and you're going to do blood work. So the pulmonary function tests are just going to determine whether you're breathing or not, whether you're able to take that inhale, whether you're able to take that exhalation. And then the blood work is really just going to be oxygenation. They're going to do an ABG, an arterial blood gas, to determine whether you're getting enough oxygen into your system to oxygenate your organs. So in general, we want to talk about shortness of breath and a shortness of breath attack. So when I was a very young nurse, which we're saying was a long time ago and we all smoked in the hospital, I didn't like taking care of COPD patients. Sorry, Ken. When you can't breathe, you get really agitated, right? You have a sense of suffocating. You can be really cranky, you can be really nasty, you can get really scared, right? So not being able to breathe is a very striking feeling. I mean, it's different than cutting yourself. You have a bad cut, you're bleeding, you go to the ER, you break something, it hurts, but you go to the ER, but you're calmer about it, right? But not being able to breathe makes us very anxious. And so we want to help our clients when they're having a shortness of breath attack. And so make sure they're sitting up, okay, so that they're able to expand their chest and they're able to take as best a breath in as they can. But you want to, sometimes if they're sitting in the chair, it's easier if they bend forward slightly or put their elbows on their thighs to just support themselves. That's a more comfortable position sometimes for them. And you want to maybe gently rub their back. You want to start from the waist and go up, because if you think about it, as we're exhaling, we're breathing that air out. So you're going in the direction of the exhale, and you're going in the direction to sort of assist them in relaxing and trying to take that exhale. And then also, pursed lip breathing is very, very effective. So we all breathe in through our nose and then go. So just go ahead and do that. Do some pursed lip breathing. You feel your abdomen engage. You feel the support that you're getting as you purse lip, as you force that air through those pursed lips. That's a way to help them with their exhale. Because remember, it's the exhale that is the challenge. Okay, it's getting that air out that's the challenge. Always be reassuring, be quiet, be comfortable. If you have a client that's having excessive episodes of shortness of breath and you're worried about some type of exacerbation of what's going on with them, you want to let us know. We want our client care managers to call the family. We want to maybe take them to see their doctor or to readjust something. But it's important that the family knows what's going on with these clients. Bless you. So on your handout, one of the sides has the stages. There are 4 stages of COPD, and the one thing I didn't mention yet, and I do want to mention, is that with COPD and smoking, you can quit smoking, but your lungs are never going to go back to the way they were prior to your smoking. So with smoking, we can quit smoking, and within a year, it's being shown now that if you have a cardiac issue or a concern, if you quit smoking a year later, your heart is healthier than it was when you were smoking the year before. But your lungs will never go back to the way they were prior. So COPD is a disease process that is permanent damage, okay? And so we're not going to be able to resolve that. And also, as I said, I was talking to my husband about this. Because of our age group, there are a lot of clients that have COPD that he deals with because of the age group and because of the smoking we all did. California's rules for not smoking in public have been in place longer than most of the country, and they're starting to see some change in these types of respiratory problems that clients are coming into hospital with. And so he was saying to me that he thinks possibly down the line that we might see a decline in the death rate, because if we're not smoking the way we used to as a society, then we're not then affecting. Now there could be other things that are going to be affecting the death rate and pneumonias and things like that in the elderly, but maybe down the line we will see a decline in COPD. But you see on this handout, in the beginning it's just kind of mild, and you still have 80% of your normal lung function, which is pretty good. By the time you possibly become very severe with your COPD, you've only got about less than 30% of your normal lung function. So that's not a lot. Because we need to breathe, right? I mean, everything we do takes breath. Everything we do. And so it can be very, very challenging, a very, very challenging disease process. And so there are a lot of complications and comorbidities that can then occur with COPD. So again, the most important thing is to have people quit smoking. But respiratory infections are a big problem. They're more susceptible to illnesses, to respiratory infections, things like the flu and colds and COVID. So you want to make sure that as a caregiver or as a family member of someone who has COPD, you want to make sure they get their vaccinations. In this age group, you want to make sure they have the pneumococcal vaccination. You want to make sure they get vaccinated for the flu, for shingles, for COVID now, because all of these viruses can affect their lungs, can put them in hospital with pneumonia if they get them. So respiratory infections are a big problem because they're compromised, and vaccination is really, really important. High blood pressure is also a problem with COPD, but it's not the high blood pressure that we think of in the vascular system. It's a pulmonary high blood pressure, okay? So what happens is that there's a pulmonary hypertension that affects the arteries that bring the blood to the lungs. And so this pulmonary hypertension, if gone untreated and severe enough, can cause something called cor pulmonale. And it's written here on your other handout. But what cor pulmonale is that it ends up that because of this pulmonary hypertension, we can end up with right-sided heart failure. So COPD can lead to heart problems. And so the most common cause, COPD is the most common cause of cor pulmonale and right-sided heart failure. And some of the symptoms that our clients have with this right-sided heart failure would be fainting spells during activity, chest discomfort, usually in the front of the chest, maybe even chest pain. There could be swelling in the ankles and feet. There could be a sudden weight gain because they're retaining fluid. There could be wheezing, coughing. Again, the cyanosis is obvious in the fingertips and in the lips, okay? And cor pulmonale can be serious and lead to death because you can have right-sided heart failure and heart attack in hospital. You're already compromised because of your COPD and a variety of other things. And exacerbations are not uncommon with people that have COPD. So we want to know what the triggers are for them. It might be pollution. It might be a respiratory infection. I know with me, allergies this time of year, it might be a big thing. The humidity in Ohio because of the lakes and the water when it's last week when it was 90-some degrees and it was so humid outside, that affects how we breathe, even if we don't have a breathing problem, right? So think about someone who has COPD who is having problems breathing anyway. So all of those things can lead to exacerbations. But there are other comorbidities that aren't even listed here. So there's bronchiectasis, if the bronchioles sort of just cave in, and that can happen. Osteoporosis can be something too that is a comorbidity. Muscle weakness, skeletal weakness, they don't eat well, so we'll talk about that in a minute too. Anxiety, like I said, most of the clients that I took care of that were in hospital were really anxious, and they are exhibiting this anxiety behaviors because they can't breathe. And then also, sometimes there might be just some cognitive impairment. They're not thinking properly because, again, they're not getting the oxygen that their body needs, that their brain needs to function appropriately. So, treatment. As I said, we're never going to make it go away. You're never going to cure it. Once the damage that is there, but you can treat the damage. You can treat them with medications. The number one treatment, though, is to stop smoking. So someone here this morning was saying her brother was in hospital, he has COPD, and he was in denial, he kept smoking until they signed him onto hospice, and then he got really terrified because he realized he's really sick, right? But up until that point, he was still smoking, even with his diagnosis and with all the problems that he's having. So denial can be a big problem for a lot of us, and smoking is an addictive, it's addictive. When I was a young nurse working in a hospital, I was one of those nurses smoking in the nursing station, and I smoked for 10 years. And it really took me to get pneumonia twice in a row, one year after the other, to really get scared at 25, and in order to quit, because I tried Nicorette and all that other stuff, and I couldn't do it, I had to literally do behavior modification. I had to quit smoking, stop going to the bars with my friends at 25. That's a big sacrifice, right? And I started working out. I mean, I started putting myself in situations where I wasn't going to grab a cigarette. And that's the only way I could get myself out of that situation for long enough to get over that nicotine addiction. Because nicotine is an addictive drug, and it's a calming drug. So a lot of people smoke because of the calming effects of the nicotine, but then they get addicted to it. Okay. The other thing too is the doctor's going to determine if they need oxygen, right? So pulse oxes on AVGs, if they're getting hypoxemic, if they're dropping their oxygen with activity, they're going to order oxygen for them. A lot of our clients are home on oxygen. We're familiar with that even if they don't have COPD. Oxygen safety is a big thing, right? And we all know what we need to do to keep our clients safe while they're on oxygen. And then the other thing too is that the doctor might prescribe pulmonary rehabilitation. Yeah.
I have a question. There's no real cure for COPD, is it?
No, there's no cure for it. You're going to treat symptoms, but you're never going to cure it. And you're never going to make it regress it, make it feel bad, go better.
Yeah, I had a family member that passed away from that. And when I would take them to the doctor, and they would try to stop smoking, and actually what you do is take her cigarettes and throw them in the trash at the doctor's office and tell the doctor I can stop smoking. And as soon as we get outside to get in the car, she said, "Would you stop at the store and get some cigarettes?" So, and I shared that with the doctor, and he said, "Well, just monitor the cigarettes because she could have a heart attack or stroke from not getting
the oxygen." Right.
As well.
Yeah.
I just have one quick. What about my husband stopped smoking, but he used the vapors. So
yeah, there's a lot of research out that they're not good. I mean, they don't know. You're still taking a substance into your lungs, right? And I know that a lot of people are using them in place of smoking, but there's still a lot of research out there that they're not good. He's better off if he could just do the Nicorette gum or something and just get off of inhaling something into his lungs. Yeah.
I was just going to mention to you too, I worked with an employee years ago who did not smoke at all, but her husband smoked. And she was the one who got the lung cancer.
Right. I mean, because secondhand smoke can be as dangerous as us smoking on our own. And that's why I said years ago, there was a lot of secondhand smoke. I mean, even if you and your husband didn't smoke, you go into a restaurant or on the planes, right? They put the smokers all the way in the back in the smoking section. Well, in the first rows, you smell the smoke. It doesn't matter, right? Yeah. Someone else have a question on there? Okay. So these pulmonary rehabilitation programs, they tend to go for maybe 8 to 12 weeks. Maybe once or twice a week, clients will go to these rehabilitation programs. And so they're educational. They're going to talk about the disease process. They're going to tell them what it's all about. They're going to give them a series of pulmonary exercises that they can do to help with their breathing. And techniques that will make it easier for them to breathe. They're going to teach them how to use their inhalers properly, because sometimes people have the medication, but they don't inhale it properly, okay? So these programs are very, very effective, and they're very good. And then if all else fails, we can end up with surgery, okay? So I do want to bring up the medications for a moment too, though. Bronchodilators are the main medications that they give to expand the bronchioles so that air can get into them and out of them. And there's short and long-term acting bronchodilators. They can also maybe get some anti-inflammatory drugs to help with the inflammation process, especially, we were talking about the emphysema that causes the inflammation. And then also, it's not good for our COPD clients to take a cough suppressant. And that's important to remember. That cough is a function of the body's trying to get the mucus out of the lungs, right? And so we don't want to suppress that cough response. We want them to be able to cough up the mucus and get it out of the lungs as best they can. So that's an important thing to think about too. But the surgeries tend to be so that what they end up doing is they try to give the part of the lung that is functioning normally more space and ability to function. So they do something like an endobronchial valve that they'll put in through endoscopy. And what that valve does is it goes into the bronchia and it allows the air to leave. Okay, so it keeps, it allows the air to exit, but it prevents other air from just coming back in, okay, when they're not breathing. And then also the more serious surgeries would be a partial reduction of the lung tissue, because what they'll do is remove the damaged lung tissue and allow the normal lung tissue to function, or a lung transplant altogether. If their lungs are so bad that they can't do anything else, they can be eligible for lung transplants. Yeah.
So when you take out a portion of the lung, does that kind of restore the normal activity of the lung? Or are you still working at a percentage of
You're still
breathing?
working at a percentage,
Oh, okay.
yeah. I mean, organs are different. The liver, if you take it out, it's not there to work. You need a full liver transplant. A kidney is the one organ where you only need a half of a kidney to function, so it's really easy to take out a whole kidney, and you still got plenty of reserve in your kidneys, and they would function normally. But if you're taking out a portion of the lung, you are still working at a handicap, at a percentage of it. Okay. Any other questions about the treatments? And the other thing too, regular activity, okay? Activity is important, exercise is important. Just walking is one of the best exercises that we can do with our clients, even for ourselves. And it doesn't only, the exercise and the activity doesn't only help to improve our general strength and flexibility and balance, but it also helps the lung tissue and muscles. The exercise also helps the lung tissues and muscles to strengthen and to work more effectively. Okay, so there is a physiological response in the lungs to doing these exercises.
So I have a client, they take the Buterol,
Mhm.
take 2 puffs, go for a walk. I mean, just a couple of steps, they out of breath.
Right.
So should the activities be eliminated or?
No, you should encourage them to keep doing it, but then you stop and rest. Stop and rest till they get their breath back, and then have her walk a
I've
little
seen
bit more. Okay.
some clients do
Yeah.
overuse their pumps and cause other problems. They
Yeah.
Start racing.
Well, yeah, I mean, and so I had supposedly, maybe I have mild COPD from my smoking, when I was 25 years old. And so my doctor gave me one of those things, the bronchodilators, when I was trying to exercise. And I'm like this, I'm so shaky because they really, they work, but they make you really agitated and shaky sometimes. And some people have a negative reaction to it.
Yes,
So it makes them more uncomfortable sometimes. And I had a short acting one because I only needed it when I was going to go, run or walk or do something like that. But you still want to encourage them to do the exercise.
Keep pushing forward.
You keep pushing, and it's hard. It's really hard. And
I get my phone with me.
yeah, I mean, and even if you think about it, the natural aging process affects our ability to breathe, right? It affects our cardiac system. It affects our strength and our musculature and our ability to be balanced. Just the natural aging process. When you've got someone with COPD and they may have coronary artery disease, or they may have congestive heart failure, right? Or they may have something else. And so all of these comorbidities, these multiple medical problems, they feed on each other. And it makes it really, really challenging for some of these people to be able to simply walk to the end of the block and
But
come back.
it seems so difficult because some of them, like you said, they overuse the medication. You give them a nebulizer, they get up and walk from the living room to the bathroom, then they want to come back and they start breathing. Then it's like, no, I mean, it's just like you said, the anxiety kicks in.
Right.
And then the breathing just gets out of control.
Right. And so, I mean, the short acting isn't to be used every time they take a short walk. It's for, yeah, and so maybe they need to be re-educated, and maybe this is a situation where you can have the client care manager talk to the family about maybe putting them back in some kind of pulmonary rehab so that they're re-educated on how to take their medications. and maybe some of those respiratory exercises that they can do, you know. But I mean, calming them down, just, you know, being patient, being considerate, letting them understand what's going on and stuff. Huh?
She sneezed.
Huh?
No, she sneezed. There's
Oh,
something.
okay, sorry. Bless you.
But I think the pump is better than getting on the oxygen tank. You know, when they have to have the little tube and oxygen tank, you know, now you're really in a critical situation because you need that to breathe.
Right,
You know,
right,
so
right.
I want to get to that point.
Yeah, and like we said, I mean, it could progress to the point where you're really in trouble. You just want to, as I said earlier, it's an anxiety-provoking disease because breathing is so important to us, and we do it without thinking about it. When all of a sudden we can't breathe, we get very nervous and very scared. And so we have to find ways to help people stay calm. And because the anxiety then is going to compound the shortness of breath because they're getting anxious and they're getting even more short of breath. So it's a challenge for us to be able to calm them down, not get anxious with them, and find ways to make them feel better. But the regular activities, the regular exercise, it's important for them to maintain that as best they can. So you guys have seen this in every workshop that you come to. We want to build trust. The fact that you're here is a way to build trust. The fact that you're learning about the disease process, about the side effects, about what you can do, so that when you go back to take care of your clients and to take the leave, you know how to respond to the signs and the symptoms that they're exhibiting. You know what to do to help them. And especially with this clientele, I mean with all of our clientele, but especially with this clientele, we want to be calming, we want to be compassionate, we want to be caring, because our demeanor and our calmness is going to help them feel more safe and secure when we're caring for them. Because remember, they're anxious anyway. So your role. You want to, and we talked about this already, you want to encourage them to exercise regularly. And you've got this 94-year-old lady that says, honey, I can't breathe and I don't want to do it, and there's nothing you're going to do that's going to make me do it, right? And we all have clients like that where they just say, not doing it. Redirect them. Find a different way to come about it. Do something else for a couple of minutes and then reapproach the situation at a time when they are more willing to hear you. We want to plan and prepare healthy meals, okay? So if these clients, they have a tendency to have weight loss, okay? And if you think about it, if you're really short of breath and you're really tired, you don't want to sit down to a big meal, right? So maybe you want to think about planning small, frequent meals for them and having rest periods before they eat. So maybe you plan the meal after a nap or after they've been sitting watching TV for an hour so that they're calm and they're rested. You want to find foods that are nutrient dense, like eggs, things where they're going to get the protein and the nutrients that they need in small meals so that they don't have to eat a big steak if they don't want to, right? And we were talking earlier too about milk, but some people, milk is a mucus producing, product, so some people may not be able to take that. But the other thing too that I want to mention, pineapple and, I'm blanking on the one right now.
Papaya.
Papaya, thank you. You could tell by my long drawing out. Pineapple and papaya have natural agents, enzymes that break down mucus. So if you can encourage them to eat pineapple and papaya, those are two fruits that are really, really good to naturally break down the mucus that's in our systems. We also want to maybe encourage vitamins and nutrient supplements and high protein drinks and things like that. There's a ton of stuff out there now on the market, and all of it isn't as bad as Ensure, which tastes horrible to me. But so there's ways to get the nutrients into our clients. We want to always avoid pollution and secondhand smoke, and in this day and age it's much easier now to avoid secondhand smoke because there's so many restrictions on where we can smoke in public. Pollution is another thing. It just depends on where you live and whether there's a lot of pollution in the air. I know that we were talking about allergies and stuff. Ohio is I came from Baltimore, and I have never seen as much like moss and stuff on the trees. I mean, my trees in my neighborhood and my house are green, from all the moss because of the wetness and the moisture because of the lakes. So that's a factor too. Maybe they're having problems breathing. You want to put them inside in the air conditioning, because the air conditioning dries the moisture out of the air and it makes it easier sometimes for us to breathe. Make sure they get to their doctors. Make sure they're doing their medical treatments. Make sure they're using their appliances appropriately. Plan appropriate activities. Be patient. Patience is hard sometimes, but that's what we do, right? We're caregivers. We're patient all the time with our clients because they need that. They need that support from us. And we want to protect them from contagious illness, right? We want to, and now, I say this, and I'm preaching to a choir, for 2.5 to almost 3 years, we're all walking around in masks, right? Some of us are still wearing them. The COVID variant right now is an increase. Right now in Ohio, increased hospitalizations because of COVID. So we want to make sure that we're protecting our clients. Maybe they don't wear the mask in the house, but if we're going to take them to the store, encourage them to wear it. And of course, they're going to put a mask on and say, I can't breathe, right? Because we put it on and say we can't breathe, but most of us are used to it. But if you can't breathe anyway, the mask makes it even more challenging. But we need to think about exposing them to a COVID variant, to the flu. The season isn't here yet, but it's coming. And I think too, in general, because we have been isolating ourselves and wearing masks for 2.5 years, we haven't been exposed to a lot of illnesses. And so a lot of people are complaining about getting a cold in the middle of the summer because all of a sudden they're out among people, and these viruses that haven't had any place to go because we've been protecting ourselves are all of a sudden making everyone sick. It's not COVID. You get sick, you test yourself, you're negative for COVID, but you got a virus. You've got a cold, you've got something. And so I think, because I remember when I was a young nurse working in pediatrics, for the entire 3 months, I was sick because I wasn't exposed to the bugs that these kids have because I was young and I didn't have children. So exposure is a big thing. We want to make sure that the person that has COPD, we want to understand, and we already talked about this, that there could be comorbidities. They could have other chronic problems that are going on that are going to exacerbate their COPD. So like we said, they can't breathe because of their COPD. The natural aging process, there's a decrease in oxygenation to the tissues anyway because of what happens to the lungs. They have congestive heart failure. Maybe they're fluid overloaded at the time and they need to be diuresed, and that is going to contribute to their not being able to breathe. So we want to know what our clients' comorbidities are and understand that most of the ones that they have, even if you don't have a medical background, most of the ones that they have are going to play on each other and make all symptoms worse than they may be without the comorbidities. They may have other challenges. They may have dementia, right? So you have a client with dementia who is acting out and gets anxious, and it's because they can't breathe, but they can't intellectually understand what's going on with them. That's going to compound their behavioral patterns. We want to understand what they can and can't do. We want to push them, but not force them to do something that we know they can't really do. And we want to work to meet their needs. We want to understand where their weaknesses are, where their strengths are, and work to meet the needs that they have. And if you have a client that's declining or exacerbating or something, again, talk to your client care manager, let us know what's going on, because we can intercede with the family, we can maybe get them to a doctor's appointment. You guys are their first line of defense. You're the ones that are with them all the time, making sure and watching the changes and seeing if they're having a bad day. And one bad day may be just because they didn't sleep well that night, but 2 or 3 bad days in a row is indicating that something is happening and something's going on and we need to check it out. Okay, so again, recognize, record, and report. It's what you do every single day. You recognize the symptoms, you recognize what's changing with your clients, you report it to the franchise, and you document it so that anyone coming in after you or the family member that's reading that journal can see what you're seeing and can understand, oh, this happened today. Well, that's kind of different from my mom. I'm going to call Sally and find out what she really saw. I'm going to call the client care manager to find out what's really been going on. Or talk to the parent. Okay, so the symptoms. Remember, the most 3 primary symptoms that we're going to look at is shortness of breath, persistent cough, and then the mucus production. And it can be white, yellow, or greenish, but remember, if it starts to turn color, look greenish, brownish, darker, you're going to suspect that it's some type of infectious process is going on. Wheezing, tightness in the chest, lack of energy, the cyanosis in the fingernails and in the lips, the blue hue to it. And if it happens, you'll see it and you'll know it, because you'll see the color, the discoloration. The complications, remember the complications, respiratory infections, it's the number one, it's a big one. High blood pressure, the pulmonary hypertension that can lead to heart disease and to right-sided heart failure are all complications. Lung cancers, depressions, exacerbations are ones that you're going to work with all the time because you're working with them on a daily basis. And then what can you do? You encourage them to exercise, you encourage them to do as much as they can to maintain whatever strength they do have. Remember, exercise helps to build respiratory muscle strength as well as your regular muscle strength stability. We want to make sure that we plan healthy meals. We want to modify them so that they get the nutrients in that they need to prevent excessive weight loss, keep them away from pollution, keep them away from pollen, things that are going to exacerbate their problems. Protect them from illnesses, all of those things that we talked about already. Okay. Any other questions at this point? Yeah?
In a client that may be bedbound, is there any way we can help them in keeping them moving since they can't get out of bed to actually exercise?
Yeah, that's a harder one. You can reposition them and maybe make sure that they're sitting up periodically so that they're not lying flat and it's harder for them to breathe. But it's hard. You can maybe just have them do arm exercises and things like that, to get their chest open and to get them moving, but you're not going to be able to get them up and walking. Yeah. But maybe even some deep breathing, have them do the deep breath, pursed lip breathing just periodically, just to get a deep breath in and to get it moving. Things like that might be helpful too. Yeah. Any other questions? Yeah.
What is it when you observe a client, and, they're breathing, but then also they'll go like this, or
They're gasping?
yeah, just.
I don't know unless I have more information on the situation or something. But and some people just do that. And why do we yawn? I can never get an answer from anyone in the medical field about why we yawn. Okay. But we end up taking a deep breath in and then just yawning and letting it out. So I think sometimes, it's just an elderly person who all of a sudden just isn't maybe, is falling asleep and maybe all of a sudden they're waking up and they gasp a little bit or something like that. Okay, guys. Okay, first question, what's your name? Okay, number 3, COPD is a group of lung diseases that block airflow, making it difficult to breathe. True or false? True. The 2 most common conditions that make up COPD include emphysema and chronic bronchitis. True. Lung damage caused by COPD can be reversed. False. Common signs and symptoms of COPD, and mark all that apply: shortness of breath, persistent cough, wheezing, chest tightness, lack of energy, blue lips or fingertips, shakiness. All of the above. Number 7, to assist a client with COPD, a caregiver can plan and prepare healthy meals, avoid air pollution, rush the client, plan activities that require a lot of activity. A and B, yeah. Complications of COPD include respiratory infections, high blood pressure, heart problems, lung cancer, depression, and exacerbations. All of the above. Regular exercise can improve the client's strength and endurance and strengthen respiratory muscles. True. Clients with COPD should not be encouraged to stop smoking. False. Clients with COPD may require oxygen therapy. True. And then number 12, if your client is experiencing shortness of breath, you can assist by asking her to lean forward slightly, hands or elbows on her knees, Gently and slowly rubbing her back from the small of her back to the neckline, encouraging her to breathe through her nose and blow out through her mouth. All of the above.
Ended up for years, went back to another pulmonary doctor, who's been great, diagnosed me with COPD, okay, which is now emphysema. I have emphysema, okay. I am one of the ones that can't take, I don't like medication too much, so I defied everything. Basically, I was even on oxygen. I went to the respiratory therapy. It was everything that was supposed to be done. I said to myself, I can't do this. I was on oxygen. I'm not going to drag this oxygen tank around with me. I felt too young. Okay, I was at that time. I'm 74 now. I wasn't going to drag no tanks around, looking like, carrying them. I just couldn't do it. So I took it upon myself. I lost 43 pounds. I started taking care of myself, eating right. I took myself off the oxygen for a long time before I seen the doctor, pulmonary doctor. We did another test. My oxygen level is up in the 90s. Okay, so I did it upon myself because I'm not going to do this. I'm going to take care of myself, your body. And I think mine started out with, I'm from Pennsylvania, coal mining town, steel milling time. And I think that's what actually started the whole thing. And then my husband, ex-husband at the time, was a smoker, like she said. You used to smoke in the house all the time. And wherever you go, people are smoking, okay? And I think that contributed more to it, and that's what had happened. But I thank God now. I'm not going to say, now, once you have it, it's never going to go away. I can tell you now, I'm going to live with this for the rest of my life, okay? But I have what's called maintenance. You maintain it. So now all I do is take one little, it's powder stuff. One little squirt of that, one today. And that's what I take. But you're going to live with this the rest of your life. I have bad days. The humidity, bad. Cold, bad. I can't be in that cold, breathing a cold, and I can't be in the humidity. So I stay with, like I said, in air conditioning. I'm still working, and I just take my time, do what I can, and that's how I do. I just live with it that way, and just thank God for every day you have. And, you never know what's going to happen with this. You know what I'm saying? So I like to say that I'm a good ending story to this, even though I've had it for 36 years. Okay? You can't live with it. You just got to maintain it. Take care of yourself. Exercise, as much as you can. And walk a little bit. You're working where you work. We work at. You got to walk anyhow. You got to help other people walk. So you're really still working. Walking and stuff. And that's all I can say. And wish everybody well as it. But you can survive it.